I'm Dr. Caitlin Houghton. My uncle Pat got diagnosed with Barrett's esophagus and came to me for advice. Uncle Pat consulted with a gastroenterologist and a foregut surgeon regarding his long segment non-dysplastic Barrett's and 3-centimeter hiatal hernia. Much of the information we received was similar, such as acid reflux leads to Barrett's esophagus, and Barrett's esophagus is a precursor to esophageal cancer. They also both explained that a hiatal hernia disrupts that natural barrier, resulting in increased acid reflux. However, the tone of the visits became dramatically different when it came to how to address these diagnoses. In this episode, I get to sit down with Dr. Appannagari and Dr. Kemp to discuss their treatment strategies for Barrett's esophagus.
So my goals for patients treating Barrett's esophagus is to prevent every patient from having cancer. If I see a high-risk lesion, I'm starting with ablation. We're solving the underlying cells, trying to get them rid of those Barrett cells. And then the next step is trying to figure out how we reduce the risk factor. Treatment for Barrett's, we already know that chronic esophageal reflux disease, GERD, is the #1 risk factor. So my goal of treatment is if I can best treat the risk factor, I will reduce their overall risk as an individual.
Uncle Pat keeps coming back to this, but I'm not symptomatic. I don't have symptoms of GERD. Those are difficult patients to deal with. And you and I know that 40% of patients who present with esophageal cancer will say, well, I never had GERD, I just presented with dysphagia. How are you gonna treat him maybe differently than someone that does have symptoms? And is symptom control enough for you?
I think we have to remind ourselves that very few pre-cancer and cancer conditions come with symptoms. It's not unique to esophageal cancer or Barrett's that they don't have symptoms. I think when we talk about GERD, GERD's a disease that can also lead to it, but we also need to focus on the benign reality of GERD disease causes people harm regardless of cancer. So we're also trying to treat that. And so oftentimes, if we can surgically correct things structurally before they have irreversible events, they're gonna have an impactful quality of life long term.
When a patient comes like Uncle Pat to your office with non-dysplastic Barrett's, what are your treatment goals for him?
Usually with these patients, one, symptoms, right? You want to make sure their symptoms are controlled. They're not suffering with uncontrolled heartburn, regurgitation, things like that. Because non-dysplastic Barrett's, the cancer risk is so low, you're not really worried about the downstream progression in these patients. You're more worried about, can they live a relatively normal reflux-free lifestyle?
It's interesting though, because I think if his symptoms are so minor, he doesn't have a lot of the typical acid reflux symptoms. It's more like some dysphagia. He did take Tums, but he really wasn't even taking medications before having this diagnosis. It's really hard then to go by symptoms alone.
It is, and it's interesting in some of these people like Uncle Pat with long segment Barrett's, it becomes long segment because they are so asymptomatic. The people that are super symptomatic are often going to present earlier. You're catching them quicker before it has the chance to either progress via dysplasia or progress via just the length of the Barrett's.
A surgeon's focus for treatment of Barrett's is more on regression, especially for non-dysplastic Barrett's. That doesn't seem to be congruent with GI community's goal of treatment are.
Yeah, I think making it very patient specific. When you're factoring in all those aspects that may contribute to a bigger likelihood of progressing, right? So a larger hiatal hernia, a longer segment at baseline. When you mix all this stuff in, then I think it does change the typical patient that we see, right? Which is, it's like you're saying, surgeons think more about regression, whereas we think about preventing progression. And then when you have your garden variety, non-dysplastic, short segment Barrett's patient, which is essentially what we're seeing on the day-to-day, for those people, I think when GIs think, and I would never do surgery for Barrett's, you're thinking of that patient, right? Because that's what we're seeing over and over again. Whereas you frame it well, when patients have these other baseline barriers, your longer segment, when that specific population, I think it kind of behooves us to think differently about that patient than the traditional patient that we see.
Uncle Pat has long segment non-dysplastic Barrett's, and I think that's kind of a gray zone because he falls in this non-dysplastic category. At least the GI guidelines are going to say to survey him in 3 to 5 years. What do you think about that, and is that appropriate for Uncle Pat?
I think in the past, when we didn't have the information, it was the best we could do. And I think with the TissueCypher, all of these guidelines are guidelines. So we're all meant to try to make an individualized decision for the patient in front of us. What's their risk tolerance? as well. With the TissueCypher, this adds a little bit of piece of information when people are in this gray zone. And I think that's what's really been valuable to me as a physician is how do I treat Uncle Pat, not the general population?
One of the arguments against doing ablation for non-dysplastic Barrett's is because if you kind of take that whole lump of patients and that whole group of patients, the argument is that it's not cost effective. Do you think that TissueCypher will help change that?
I do think it will. I think it may downgrade and give us some reassurance to patients and actually be a cost savings that we don't have to do endoscopies as frequently on certain individuals. And certain individuals, we need to be vigilant about treatment. We know that optimal treatment is cost effective. The argument of this cost effectiveness, there's so many Barrett's patients. Well, which ones are the ones we need? Well, we got to do them all if we're going to prevent cancer. Well, maybe we don't. Maybe we have a good test to help us.
In Uncle Pat's case, his TissueCypher score came back low. However, if you look at it, we've seen that his score is actually pretty close to intermediate. Would that change the way that you approach his case in particular?
I would, between the fact that it was long segment, also the fact that he was so borderline to intermediate, I probably would not even want to wait the full 3 years as the guidelines say, because as we get more information, we don't have to just put people in the bucket of non-dysplastic, low grade, high grade, right? There's room for nuance now. And when you have room for nuance in classifying patients, I think there's room for nuance in when you're bringing them back.
In Uncle Pat's case, given that he does have the structural abnormality of the 3 centimeter hiatal hernia, is there ever a scenario where you would not recommend that he gets that fixed?
If they meet the surgical candidacy, they're a good surgical candidate, I don't know why I would offer them a procedure that could lower their risk of disease progression. Why wouldn't you want to fix something that you know caused the problem? What I've gotten in the past answer is sometimes it's the fear of surgery alone. I think we need to discuss with the GI doctors of just making sure that surgery is part of the pathway of consideration.
Uncle Pat also has this 3 centimeter hernia. And we know that even if we ablate him, if we have that ongoing reflux, which he's not feeling very well, but if we have that ongoing issue, the ablation might not be as successful. We know that ablation recurs more often when there's uncontrolled acid reflux or if there's a hiatal hernia. Do you think that there's a role for surgical intervention in that case, or would you hold off?
It's interesting, you know, the question of surgery as a anti-neoplastic measure in Barrett's esophagus. As GIs, we're always taught surgery is for symptoms. But when you break it down like that, yes, he has a hiatal hernia, he has a barrier issue that's going to be ongoing despite ablation, I do think that it's not an unreasonable discussion to have. But at some point, you have to look at the overall expectancy of cancer in his lifetime. As GIs, we're also taught putting patients at risk for surgery, complications during the procedure, after the procedure, post-Nissen complications and things like that versus a lifetime risk of getting esophageal cancer. I think that's why we're always taught it's purely a symptom thing. But I do understand where you're coming from, where that barrier disruption is not going to go away.
So what's the overall perception of surgery in the GI community? And has it changed over time, or are we still kind of scarred by the older, less progressive surgical data?
You're kind of taught all the way through in GI, your goal is to prevent surgery. And we're trying to avoid patients from proceeding with surgery. I would say a lot of GIs are not as well versed in some of the newer techniques and what lower risk they might carry in terms of recovery time and also improvement of symptoms. I do think there's a lot of room to expand that knowledge, right? And I do think if a lot of GIs maybe were aware of some of these newer innovations, that they wouldn't be quite as hesitant to send patients to surgery.
These conversations were so impactful. No wonder surgeons and gastroenterologists often feel tension. Surgeons see the underlying structural dysfunction and want to restore it, while gastroenterologists are actively trying to avoid surgery by using medications alone to treat symptoms. Dr. Appannagari pointed out that our perspectives are often shaped on the majority of patients we see. Gastroenterologists are more likely to see patients earlier in their disease progression, while surgeons are really seeing them at later stages. If we could use our differing perspectives and skill sets to our advantage, I know our patients would benefit greatly. Stay tuned for next week as I sit down with Uncle Pat to discuss how these consultations have shaped his goals for treatment.